Can you tell me when? Yes?
I think you need.
Oh, I need to use this one. Can you hear me better now? Yes? I can still see things are coming in, so people are coming in, so this is great. So thank you so much. Welcome to the PhD defense of Irene Martinez-Morata, Dr. Irene Martinez-Morata. It's an honor for me. I am, for those of you who might not know me, I believe most people know me, but I am Ana Navas-Asien. I have the honor to serve as a mentor, advisor to Irene, together with Mary Gamble, Dr. Mary Gamble, who is sitting here at the front. And this is a tremendous honor, and it's a big day. It's a big day for our department, for our school. I always think there is not biggest day in a university than when you have a PhD student defending their thesis. It's really el día grande, I have to say it in Spanish. And it's a very, very exciting moment to see Irene's journey that she's going to present to you in part, because Irene has accomplished so much that she had to be very selective in what she was going to present so that it was manageable in terms of the time. Irene has had a remarkable career so far. She has an MD degree from the University of Murcia, which is in the southeast part of Spain. She did work there and also at one of the biggest universities and hospitals in the area. And we were extremely fortunate that at the time that when she was finishing her medical studies, she developed this strong interest in environmental health. She worked at the World Health Organization with Maria Neira, who is now the director of the Climate and Health and Air Pollution Programs. She actually wrote a book, Irene, that I am sure she was very influential, that the WHO published. She also worked in Uruguay on lead poisoning prevention programming, working with pediatric units. So she very early on had hands-on experience on how to do environmental health medical practice. Those experiences were very influential, and she decided to pursue a master in environmental health sciences. And she told me that of all the programs that she looked around in the website, Columbia University was the one that looks the most interesting, the most engaging, the most interdisciplinary, and that thus made her decide to come here for her master. She got a Fulbright to do that, which is, as you can imagine, super competitive, and she was able to secure that funding. Then the pandemic hit. I think you can all remember that she was the year one of her master program. She went back to Spain with an incredible dedication to service in the pandemic during those times. She worked in the morning in the hospital, doing lots of important surveillance for the COVID pandemic. And in the afternoon, she attended all her classes during her master's. She TA'd for Mary Gamble, her nutrition class. And so she was fully dedicated during that year. She also did important research on COVID, working in an interdisciplinary project with the faculty here in the Department of Epidemiology, bringing together lots of people in the psychiatric units in Spain to look at the impact of the pandemic in health professionals. And she was published some of that work. So it was incredible when Irene told us that she actually wanted to continue to work with us because she could decide anything she wants. You know, she has done incredible things. And so she applied to the PhD program. As maybe some of you know, as a foreign student, it's really challenging to fund your PhDs here, but Irene secured additional funding through a very prestigious grant from La Caixa Foundation. So now she came with us, and she has done incredible work. She secured also an additional grant through the Casey Donnelly externship from the NIHS Superfund Research Program that allowed her to give additional collaborations with the University of New Mexico. And it's been an incredible honor and pleasure to serve as a mentor, because I think she's our mentor. That's the way I always think myself. I always think the students know so much more than I do. But in Irene's case, it's been remarkable. So thank you, Irene. We are looking forward to your presentation.
Okay. Thank you, Anna, for your amazing introduction. And thank you all today for coming. I hope we can enjoy this moment together. And I'm going to do my best and present the final defense for my dissertation entitled Metal Exposure and Cardiovascular Health, Characterizing Novel Risk Factors for Heart Failure. So today, this always happens.
First, that's a trick that you need to do like this. Try now. Yeah, click in the.
No, it's working. Okay, so I'm going to start by sharing some of the motivation and introducing the dissertation framework. Then I'm going to overview 3 of the projects inside my dissertation to finalize with some conclusions, implications, and future directions. Cardiovascular disease, as you may know, is the leading cause of mortality worldwide. It's estimated that 20% of deaths are attributable to cardiovascular disease, and 1 in 3 cardiovascular disease deaths are due to heart failure. 6.7 million adults older than 20 years old have prevalent heart failure in the United States. And heart failure mortality is increasing. This map is showing the trends in cardiovascular disease deaths over the past decade. As you can see, while cardiovascular disease mortality has decreased in some regions, in part due to improvements in healthcare accessibility, treatment, and public health efforts, heart failure mortality has consistently increased by more than 20% across the country, showing the critical need for novel approaches to reduce disease burden, including public health actions. And I'm sorry because this used to be a video, but it's not going to work today. So I'm just going to tell you what is heart failure. And heart failure is a complex clinical syndrome that is caused by a functional or structural cardiac abnormality that results in the reduced ability of the heart to pump enough blood or to fill in with enough blood. And it can affect the whole heart, it can affect the right side, the left side, and it usually results into the inability of the heart to pump enough blood into your lungs and also into the rest of the body. And heart failure is a disease that has a long preclinical period, which is a period when the patient does not show and does not have any apparent symptoms. This period is followed by what we call the clinical disease, which has, unfortunately, high mortality rates of up to 30 to 50% at 5 years, which is comparable to the mortality rates after the diagnosis of cancer. During the preclinical period, there are 2 stages. One stage where patients can have risk factors without underlying disease, which is classified by clinical guidelines as heart failure stage A. And then another stage when the patient has some structural or functional changes, but they still not show any symptoms, what is classified as heart failure stage B. And some of the well-established and modifiable risk factors for heart failure include smoking, obesity, diabetes, hypertension, etc. However, a growing body of evidence is pointing out at the role of environmental exposures such as toxic metals, air pollution, heat exposures, etc., as key modifiable risk factors for cardiovascular disease. In fact, it is estimated that 30% of cardiovascular disease mortality alone is attributable to environmental factors. Today, I'm going to focus on toxic metals and metals. Contaminant metals, such as arsenic, cadmium, and lead, are recognized cardiovascular disease risk factors, as you can see in this recent statement by the American Heart Association. This official recognition adds to a growing body of evidence, mechanistic evidence, and epidemiological evidence, including our previous work in the multi-ethnic study of atherosclerosis and ethnically and racially diverse US adults, where we identified associations between higher levels of urinary cadmium, tungsten, uranium, cobalt, copper, and zinc, 6 different metals, and higher risk of incident cardiovascular disease and all-cause mortality. And this association is graphically represented in these graphs that is showing the dose-response relationship. And as you can see, as the levels of the metal, in this case, cadmium and tungsten, increase, there is a consistent higher risk of suffering a cardiovascular disease event. And this trend was similar for the other metals, but I'm only showing these two for simplicity. In addition to these observations for individual metals, we implemented some recently developed statistical methods that I will introduce later to assess the role of not only metals individually, but of exposure to contaminant metals as a mixture on cardiovascular disease. And when we put together these 6 metals in a mixture, we identify that higher levels of this 6 metal mixture is associated with increases in cardiovascular disease by 29% and a 60% increase in the risk of all-cause mortality. In an additional model, where we included a larger panel of metals, 15 in total, the risk was attenuated, which suggests that not all metals are contributing to cardiovascular disease, and this also highlights the need to identify which are the mixtures that are driving the risk and which are the contaminants in the mixtures that are driving the risk. Some of the established mechanisms of metal-induced cardiotoxicity include increased oxidative stress, direct endothelial damage, and atherosclerosis. However, compared to other cardiovascular disease endpoints like atherosclerosis or ischemic heart disease, for which metals are established risk factors, the available evidence on the role of exposure to metals on heart failure pathophysiology requires further study. A handful of previous studies have identified some associations between arsenic, antimony, and cadmium, as you can see on the slide, suggesting that metals, as I said, are likely to play a role in heart failure pathogenesis, but we still need to do more research. And exposure to metals is widespread in the environment, and it occurs through multiple routes and sources of exposure, including exposures that occur at the community level, like air pollution, contamination of drinking water, or contamination of soil, but also some exposures that are driven by individual behaviors, such as smoking, vaping, use of consumer products, or dietary patterns. Disparities in exposure to toxic metals are widely documented across population groups in the US, particularly affecting historically marginalized communities, such as communities of color and populations with lower socioeconomic status. Racial and ethnic disparities in exposure to drinking water metals like arsenic and uranium have been documented by our previous work, where we identified that higher proportions of Hispanic and Latino and American Indian and Alaskan Native residents living in a given county was associated with higher levels of these toxic metals in their water. And similar findings were identified for non-Hispanic Black communities in the Southwest, where arsenic and uranium in soil and water are high, as you can see on the map shown here. And these findings reveal the importance of structural factors, including structural racism, as major drivers of disparities in exposure to environmental toxicants. Disparities in cardiovascular disease burden also exist and persist. In this dissertation, we're going to focus on American Indian communities in the United States, where cardiovascular disease is epidemic, and cardiovascular disease is the primary cause of premature mortality. American Indian communities suffer a long history of discrimination and social injustices that have resulted in disproportionate exposures to toxic metals, social stressors, and a higher burden of cardiovascular disease risk factors that are also relevant for heart failure. Despite the high burden of cardiovascular disease in this population group, heart failure remains understudied. So altogether, the evidence reveals the need for characterizing novel risk factors of heart failure, including the role of emerging environmental factors such as metals and metal mixtures, with a focus on historically underrepresented populations and populations group who suffer a high burden of cardiovascular disease, as well as the need to develop novel approaches for disease prevention, including interventions to mitigate the health impacts of environmental exposures. And these research needs motivate the conceptual framework for this dissertation, which you can see here. But today, for simplicity, I'm going to be presenting on 3 projects that aim to address those gaps. In the first project, we will characterize risk factors of heart failure in American Indian communities in the Strong Heart Study. Towards our goal of identifying novel risk factors of heart failure, we will assess the associations between urinary metals and incident risk of heart failure across 3 different population cohorts. And last, we will identify and evaluate new opportunities for the mitigation of metal toxicity through nutritional interventions. This first project, as I already introduced, is motivated by the need to characterize risk factors of heart failure in American Indian communities. So as I said, cardiovascular disease is epidemic in this population group, and American Indian adults suffer a high burden of diabetes, hypertension, obesity, which are known contributors to heart failure risk. However, despite the high burden of cardiovascular disease mortality, the incidence of heart failure in American Indian adults remains understudied and actually underreported in nationwide statistics. And as you can see on the table, that is showing the statistics from the American Heart Association from 2023. And previously developed heart failure risk scores that are currently used and implemented in clinical practice, like the Framingham, the MESA, or the ARIC cohort, did not include any American Indian participants. This motivates our project, where we aim to develop a heart failure risk prediction equation that accounts for relevant cardiovascular risk factors that are affecting American Indian communities, and to estimate the incidence of heart failure in the Strong Heart Study and identify high-risk subgroups. So our study population is the Strong Heart Study, which is the largest epidemiological cohort of American Indian adults in the US, which recruited more than 3,000 participants from Arizona, Oklahoma, North Dakota, and South Dakota. At the baseline visit, participants were 44 to 75 years, and for this project, they were followed through 2019, even though the cohort is ongoing. Heart failure events were ascertained over this period by a panel of physicians through an extensive review of medical records. And as I mentioned before, heart failure is a very complex disease, and the clinical diagnosis is based, as you can see here, on several clinical criteria, and sometimes it even requires imaging diagnostic techniques. So to be able to conduct this work, we first conducted an extensive review of participants' forms and study charts to be able to rigorously ascertain heart failure events during the follow-up. And this work also allowed the identification of heart failure subtypes, which are very important for the characterization of the disease, but I'm not going to go into detail over those results for the sake of time today. For our methods, we estimated the incidence rates, and then we fitted multiple Cox proportional hazard models, including several risk factors, to estimate the hazard ratio, which is an indicator of the relative risk over time, at 5 years, 10 years, and 20 years to suffer a heart failure event. And then we also evaluated the model performance using a statistics that is called the C-index. That is a measurement that allows us to evaluate how good is our model in predicting the event based on the data that we actually have and what we actually observe in the population. So at baseline, participants who developed heart failure were older, more likely to be female, to have a history of smoking, established diagnosis of diabetes, or a presence of albuminuria, which is an indicator of early kidney dysfunction. Over the study follow-up, a total of 507 participants developed heart failure, resulting in an incidence of 9.5 cases per 1,000 years. Higher incidence was documented among participants with a baseline diagnosis of diabetes, with higher levels of HbA1c, which is the term for glycated hemoglobin, which is an indicator of sustained high levels of glucose in your plasma or in your blood, or the presence of albuminuria. And the incidence rate that we documented is higher than other cohorts of adults that have a similar age. For example, the incidence of heart failure among non-Hispanic Black participants from ARIC was 5.7 cases per 1,000 person years, and for non-Hispanic white participants in MESA was 2.5 cases per 1,000 person years. Moving on to our main results, in our models, we identified that important predictors of risk at 10 years included age, smoking, having a higher body mass index, diabetes diagnosis, dysglycated hemoglobin that shows up here again, albuminuria, and having a previous myocardial infarction. And the model achieved a good prediction performance of 0.77. So the C-index, as I said, serves us to know how good is our model doing. And a C-index that is larger than 0.5 and as close as possible to 1 is considered to be good. In our models, I wanted to highlight another result that we identified that indicators such as glycated hemoglobin or albuminuria, which are independent predictors of risk, even after accounting for having a diagnosis of hypertension or diabetes, which shows the importance of not only detecting these clinical factors, but also the long-term management and having a good control of your blood pressure, of your glucose, and of your other risk factors to intervene on the risk. So in summary, we identify that heart failure incidence is high in the Strong Heart study, revealing that heart failure incidence is underestimated and underreported in American Indian communities. In this population, indicators of diabetes and diabetes control, which are not currently included in clinical guidelines, play a key role in heart failure development and can help the identification of high-risk individuals in American Indian communities and other populations with high diabetes burden. And the findings for this study were published in the Journal of American Heart Association. They are coming in press soon, hopefully, and they can directly inform clinical practice because for our models, we use measurements that are routinely available in primary care settings. Now we're going to move to the next project. We're motivated by the need to identify novel risk factors. We assess the role of urinary metals on incident heart failure across different cohorts of adults. And as I said before, metals are established risk factors for cardiovascular disease, but there is still limited evidence for metals and heart failure, which reveals the need for prospective studies with a high-quality outcome ascertainment, also studies that include diverse populations and populations living in different geographical areas, given that geological context is very important for the occurrence of metals, as well as studies that assess the role of metals individually and as metal mixtures. So our study objective was to evaluate the prospective association between urinary metal levels and incident heart failure across 3 US cohorts. For our study population, the first cohort is the Strong Heart study, which I already introduced. Then we also included more than 6,000 adults from the multi-ethnic study of atherosclerosis, which is an ongoing multi-center cohort study of 6 urban communities. And our last population was the Ortega cohort, a cohort that recruited adults from a region in the north of Spain, and that was specifically designed to be representative of the Spanish population, and more than 1,000 participants from this cohort were included. Across the 3 cohorts, participants were followed until the end of 2019. For our exposure assessment, we use urinary biomarkers, which are good indicators of external exposures and internal dose as urine integrates multiple routes and sources of exposures that I presented earlier. It's important to note that metals can be non-essential, like arsenic, lead, cadmium, and tungsten. These metals are toxic. They have no biological function, and high levels of these metals in the urine indicate external exposure and accumulation in the body. There is also a group of metals known as essential metals or biometals that include copper, cobalt, selenium, or zinc. These metals have a biological function at low levels, but they can be toxic at high levels. So high levels of these metals in the urine can indicate cardiometabolic dysregulation as well as excess in exposure. And across the 3 cohorts, urinary metals were measured using inductively coupled plasma mass spectrometry, and they were consistently adjusted by creatinine to account for urine dilution. And this table is showing the metals that were measured across the 3 different cohorts. As you can see, 5 metals, arsenic, cadmium, molybdenum, selenium, and zinc, were measured in the 3 cohorts. Tungsten, cobalt, and copper were measured in 2, and uranium was only measured in MESA. For our methods, we assess the relationship between individual metals and incident heart failure risk using multiple Cox proportional hazard models with a flexible assessment of the dose-response relationship. And then to estimate the hazard ratio across the different cohorts, we fitted a fixed effects meta-analysis. And we decided to use a fixed effect meta-analysis because under a limited number of studies, in this case, we had 3, these fixed effects provides a more conservative estimates and minimizes the influence of between study variability. We adjusted our models progressively. Our simplest model was adjusted for a series of sociodemographic and behavioral covariates. And then we had a fully adjusted models that also included clinical covariates, and models were stratified by study site or center in MESA and strong heart study as needed. And this method I introduced earlier, motivated by the need to evaluate the role of metal mixtures and joint exposures on incident heart failure risk, we implemented a recently developed statistical methods by our colleagues in the biostatistics department, the penalized Cox elastic net. This method allows conducting variable selection and effects estimation in the context of mixtures and also including survival outcomes, which is something that up to very recently was not possible. So for our main model, we included the 5 metals that were consistently measured across the different cohorts: arsenic, cadmium, molybdenum, selenium, and zinc. And we estimated the hazard ratio and the 10-year survival probability difference per 1 increase in the interquartile range of urinary metals. At baseline, participants who developed heart failure over the study follow-up had slightly higher levels of non-essential and essential metals. And moving on to our main results, this figure is showing the hazard ratios and the confidence interval of incident heart failure risk by doubling of baseline levels of metals. And each of the individual colored lines is showing the estimates for the individual cohorts. And then the black line with the triangle is showing the estimates from the meta-analysis, which is what is also shown numerically. And what we observe is that a doubling of the dose of non-essential metals such as cadmium and tungsten was significantly associated with a 15% and a 7% higher risk of incident heart failure, respectively. When we assess essential metals, we consistently identify positive and significant associations between higher levels of urinary copper, urinary cobalt, molybdenum, and zinc, with the largest magnitude observed for copper, with an increase in heart failure risk of 31% by doubling of the baseline concentrations of metal in the urine. And the associations remain consistent from those models that I just showed you to the models where we used a flexible assessment of the dose-response relationship using quadratic splines. So as you can see in the figure, higher levels of baseline urinary metals, in this case, arsenic and cadmium, are consistently associated with increases in the risk, of course, with some differences across cohorts, but overall, the direction of the effect remained consistent across them. And these results were also observed for essential metals, but I'm not showing them today for simplicity. Then, when we move on to assess the joint effects of the mixture, including these 5 metals, onto the risk of incident heart failure, we identified consistently positive and significant associations in MESA and the strong heart study in our model that was adjusted by sociodemographic and behavioral covariates. In our fully adjusted model, where we also included some clinical covariates, we see how these associations are attenuated but still remain significant, which is likely showing the very complex relationship that metals have not only with heart failure, but also with other risk factors that are important for heart failure. We also assessed the 10-year survival probability difference, because while the hazard ratio provides an estimate in the relative scale, which is very useful and informative, we decided to include the survival probability because this estimate has a more causal interpretation and gives a sense of the magnitude and importance of metal exposure on the overall incident heart failure risk. And what we observe is a consistent decline in the probability of not having a heart failure event by increasing levels of urinary metals, with the largest magnitude observed across participants in the strong heart study. So in summary, we identify that urinary metal levels are robust predictors of heart failure risk, and our results are consistent across individuals and mixtures analysis, and also across different and diverse population-based cohorts. And these findings can open new perspectives for disease prevention by reducing metal exposures. Okay, so we have now demonstrated the role of metals as cardiotoxicants, including heart failure, revealing the importance of reducing the exposures to reduce toxicity. But what if, in addition to doing this, we can intervene on metals body burden? And this is what motivates the last project that I will be presented today. This project has an innovative approach to disease prevention and builds upon a handful of previous studies that have identified that nutrients can interact with metals, metabolism, and toxicity. And particularly, I will focus on arsenic. And arsenic is an established cardiotoxicant and also a carcinogen that remains a major public health concern among several populations worldwide, including Bangladesh, which is highlighted here in the map, where it's estimated that more than 50 million people are exposed to high levels of arsenic above the maximum contaminant level recommended by the WHO. And to put you in context, the metal levels that this population experience are much higher than the metal levels that I showed you for the MESA, the Strong Heart study, or the Ortega cohort. So this project is motivated because previous studies have shown that folic acid can interfere with arsenic metabolism by accelerating its methylation and elimination from the body. And this process is possible because folate and arsenic, in a way, interact through one-carbon metabolism, which is a key metabolic pathway that is needed for cellular growth and development. Let's see in a very simplified way how. So folate is the main methyl donor to one-carbon metabolism, and one-carbon metabolism is needed for the methylation of arsenic into least toxic species that can be then excreted out of the body. Therefore, the rationale is that higher levels of folate, which is the direct product of folic acid, results in an upregulation of one-carbon metabolism that results in increased arsenic methylation and therefore elimination. And increases in arsenic methylation, we can document this process happening, leveraging biomarkers like blood and urine. So an increase in arsenic methylation would be translated into decreases of inorganic arsenic and monomethyl arsenic, which are the most toxic species, and increases in dimethyl arsenic, which is the least toxic species that is rapidly eliminated through the urine. And these findings have been, and this mechanism has been previously documented and demonstrated in adults from a randomized controlled trial in Bangladesh, the FACT trial, where, as I'm showing in this figure, participants receive folic acid supplementation, and after 12 weeks, participants who received the supplements, as shown by the red and the purple lines, had significantly lower proportions of urinary monomethyl arsenic compared to the placebo that is shown by the black line. However, there are no studies in children, and children are a particularly vulnerable population where one-carbon metabolism plays a key role for growth and development. So this motivates our study, the arsenic and B vitamins study in children, which is a randomized controlled trial of folic acid and B12 supplementation that aims to assess the effect of this supplementation on arsenic toxicity as measured in blood and arsenic methylation as indicated by urine biomarkers. The study population were children 8 to 11 years old that were all drinking water with very high levels of arsenic. And at the beginning of the study, all the participants were encouraged to switch to a low arsenic well that was identified by the study personnel. A total of 240, were randomized to receive either 5 micrograms of B12 and 40 micrograms of folic acid or placebo over 12 weeks, and biomarkers were collected at different time points. We use generalized estimating equations to assess the effects of treatment over time. And moving on to our main results, after 12 weeks of supplementation, we identified that participants who received the supplements had a 14% higher levels of dimethyl arsenic in their blood, which is this least toxic metabolite that I explained before. And only after 1 week of supplementation, participants who received the supplements had lower levels of inorganic arsenic and monomethyl arsenic in their urine and higher proportions of dimethyl arsenic. So consistently, this randomized control trial of folic acid and B12 supplementation show the potential of nutritional interventions with folic acid and B12 to increase arsenic methylation in children, reducing the toxicity while improving their nutritional status. And these interventions show the potential for population-level nutritional interventions to reduce the body burden of metals in disproportionately exposed populations across the world. And though this is an emerging field, another example of a recently and ongoing study of zinc supplementation to reduce oxidative stress induced by metal exposure is a supplementation trial in the Navajo Nation that I wanted to show you, where it's estimated that more than 600,000 Native American residents live within 10 kilometers of an abandoned rock mine, being at high risk of contamination by heavy metals. So the rationale underlying this supplementation is that zinc, which is a metal but is also an established antioxidant, can interfere with this mechanism that I highlighted before of induced toxicity through oxidative stress. And this university is led by the University of New Mexico, and I had the opportunity to collaborate with them, and it's shown here in this picture in one of the fieldwork visits a few months ago. Okay, so moving on to the conclusions, implications, and future direction. In this dissertation, we have explored and presented new opportunities and avenues for disease prevention by characterizing novel risk factors of heart failure. We developed an innovative risk prediction model to improve the assessment of heart failure in American Indian communities and populations with high diabetes burden, identifying the indicators of diabetes and diabetes control, as well as early kidney damage, play a key role in disease development. Additionally, towards the goal of identifying novel risk factors, we present the results from the largest epidemiological study of metals and incident heart failure, where we observe that metals are robust predictors of disease risk. And last but not least, we contributed to a growing body of evidence that is identifying interventions to reduce metal body burden and toxicity in vulnerable population, particularly the role of folic acid and B12 supplementation to reduce arsenic toxicity in children. And altogether, our findings reveal the importance of integrating epidemiological evidence and the evidence that we are generating in environmental health to clinical practice, towards the goal of reducing cardiovascular disease mortality and protecting the most vulnerable population. So in my idealistic idea, I believe that one day, the same way that we screen our patients or treat our patients for diabetes or hypertension, we do the same for established cardiotoxicants like arsenic, lead, cadmium, etc. By bringing in environmental assessment into clinical practice, we really have an unprecedented opportunity for impact. And that's what I'm getting there. It's so nice they left some tissues here. Okay, so I wanted to share a really valuable lesson that I learned during my PhD, which is the principle of the seventh generation, which is to think of the seventh generation that is coming after you in your words, your work, and your actions. And to remember the seventh generation who came before you. Okay, and I'm gonna move to the acknowledgements. If you don't mind, I'm gonna take a sip of water. Okay, because I have a lot of people to thank. So I'm just getting ready. Okay. So first, I would like to sincerely thank my mentors, Dr. Ana Navas-Acien and Dr. Mary Gambo. Anna, I am incredibly lucky and fortunate to have you as a mentor. Thank you for always guiding me to see the positive side of things and also to show me that it's possible to do very, very high level and rigorous research while still being kind, compassionate, available, and supportive. I will never forget, I don't know if you remember, but I will never forget the day that I walked into your office when I was a master's student and I just arrived from Spain and I was so lost. I knew I wanted to do research, but I was very lost. And then you sat down with me and you showed me how amazing this science is and what's the beauty of environmental health, and you opened this field for me. And I am incredibly grateful for that. And it's very hard to express in words how grateful I am. I also want to take just one sentence to congratulate you for your new position. I think the Environmental Health Sciences Department is really, really very lucky to have you. Mary, thank you so much for all your support since the first year of master. We went through the pandemic together, and I know we have a long history coming ahead. Thank you so much for showing me that the devil is in the details. And also for opening the amazing field of nutritional sciences to me, because it's been a really amazing opportunity for growth and development. I hope that one day I can be as an amazing mentor as you both have been to me. I want to thank my committee members, Dr. Annie Nigra, Linda Valerie, Alison Kupsko, Yifei Sun, and Dr. Daichi Shimbo. Thank you for always being available, for being flexible. And I think your expertise has honestly greatly contributed to this dissertation. And something I really love and the beauty of epidemiology and environmental health sciences is that the successful work is the product of teamwork, collaboration, and creativity. There's no other way we can do science that is impactful and science that matters. So I am really grateful to have been able to collaborate with amazing scientists and teams from so many different places that have always been such a guidance and support for me. I would like to thank the study participants, because the science wouldn't be science without participants, and they are really at the core of this work. I also want to thank the funding sources, the Environmental Health Sciences Department, the Superfund research team at Columbia, the amazing Metal Lab. And I want to give a special mention to my colleagues and friends, Arce Domingo, Caitlin McGraw, Annie Nigra, and Will Lieberman, because you've been always be there for me, not only as colleagues, but also as friends. So thank you for being here today. Okay, and with that, full pictures. Okay, and I'm going to do this part in Spanish because I love English, but my heart speaks in Spanish. Así que quiero dar las gracias a mi familia, a mis padres, que se han cruzado el mundo para estar hoy aquí apoyándome. Gracias por siempre apoyarme, aunque signifique mandarme lejos de vosotros. Y la educación y los valores que me habéis inculcado siempre son, de verdad, el arma más valiosa que poseo, y sin ellos yo hoy no estaría aquí. También le quiero dar las gracias a Pedro. ¿Dónde está? Hasta aquí. Gracias por tu apoyo incondicional, por tu amor, por tener paciencia cuando yo no la tengo. Y quería enseñar estas fotos aquí porque una foto es el día antes de que yo me mudara a Estados Unidos y otra fue solo hace un par de semanas. Estoy muy orgullosa de todo lo que hemos conseguido juntos y estoy muy feliz de que seamos un equipo y que lo sigamos siendo, y te quiero mucho. Gracias a mi hermana, que siempre es mi mejor aliada, y ha estado ahí siempre para mí cuando he necesitado levantar el teléfono. Gracias a mi familia que me está viendo por Zoom, a Elena, a Carla, a los que están y a los que ya no están. Y por último, es imposible pensar en este doctorado sin dar las gracias a todos los amigos maravillosos y todos los amigos increíbles que me han acompañado. Gracias a mi familia de Nueva York por hacerme sentir en casa incluso cuando estoy muy, muy, muy lejos. Y gracias a los de siempre por apoyarme, por seguirme y por vuestra amistad incondicional, aunque a veces yo no sea la mejor respondiendo a los mensajes de WhatsApp. Gracias de verdad por alegraros por mí, por celebrarme y apoyarme, aunque cuando yo os vengo súper contenta a deciros que he publicado un paper en Circulation y no tenéis ni idea de lo que es, aún así me celebráis y os alegráis por mí. Y por último, quiero dedicar mi tesis a... Ok, last sip of water. Quiero dedicar mi tesis a dos mujeres que siempre me han inspirado y me han guiado en la vida. Y son mis abuelas. Para mí, ellas son el ejemplo de lucha, de superación, que yo intento aplicar cada día a mi vida y a mi trabajo. Así que gracias a vosotras, abuelas, porque vosotras sois las mujeres guerreras de vuestra generación, que habéis abierto el camino para todas las que venimos detrás. Y sé que me habéis cuidado y que me vais a seguir cuidando porque siempre vais a estar conmigo. Así que, abuelas, esta tesis es para vosotras con mucho amor, con gratitud y sobre todo con mucha admiración. And thank you. Sí. Okay, I think now is the turn for questions. Wait, I think